My name is Monique Minnema. I work as a hematologist at the UMC Utrecht Cancer Center, and I will be your host for this afternoon, and I will also be the first speaker. Before I start, I would like to remind you all of your Ask the Doctor questions. Please fill in some questions on your cards and deliver them to the box that's outside this room during the coffee break when we have coffee. We have this afternoon 5 speakers, and after that the Ask the Doctor session. And this will be a more clinical part of the program. So I will start. Don't know if can you put my presentation? I will start to talk about some disease morbidities, so some additional complaints patients can have with Waldenström's disease. Where can I look? I can look here. It's about polyneuropathy, Bing-Neel and amyloidosis. First I will start with some basic information about Waldenström's disease. As you all know, it's a cancer, and the cancer is present in your bone marrow, and the bone marrow is normally the place where all your blood cells are being formed, so it's a kind of a fabric. The Waldenström cells are composed of B lymphocytes, plasma cells, and when you get the result from your doctor, it will be a percentage, so he will tell you your bone marrow is infiltrated for 20% of the total population of cells in your bone marrow. In your blood is the abnormal M protein, so your wrong protein, it shouldn't be there. And it's being called M protein or paraprotein, we mean the same with that. And when you get a result back from your doctor, it's always represented as gram per liter, so it's a different unit behind it, so you know what you're talking about. But besides your bone marrow, there can also be other places where these cancer cells can be present. That can be your spleen, that's not so abnormal. It can be your lymph nodes, of course, so they are throughout your whole body. And it can also be your brain, and that's depicted here. And that's very rare. Waldenström's is a rare disease, but only 1% of the Waldenström patients have cancer cells in their brain, and that is called Bing-Neel Syndrome. And I will start with explaining something about Bing-Neel Syndrome. I have a bit difficulties turning from side to side, yes. Well, Bing-Neel Syndrome is a very rare syndrome, and I think many doctors, even hematologists, haven't heard from this syndrome before. And it's also a very difficult syndrome to diagnose because the complaints patients have are very diverse. You can have some mood disorders or some psychic problems, but you can also have some diminished strength in one of your arms or legs, cranial nerve loss, so for example you have like a paralysis of your mouth because one of your nerves is involved. You can have neuropathy. It can be a sign of also of polyneuropathy, but it can also be a sign of Bing-Neel. Balance disorder, so unsteady walking, dizziness, pain in your neck, in your back or your legs, or memory loss. So these are complaints that are not that rare in the general population, but it's very rare if they are caused by Bing-Neel syndrome. What's very important that you can have Bing-Neel syndrome as a Waldenström patient while your M protein is stable. So when you have new complaints and the doctor is telling you, but your M protein is stable, so there can't be anything wrong with you, that's not the case with Bing-Neel syndrome. You can have a relapse with cancer cells in your brain, but the bone marrow and the blood stays the same. Oh, next one. So how do we diagnose Bing-Neel syndrome? So the first important step is to get that all the doctors are aware of the syndrome and that they think about it, because for diagnosis you need some invasive procedures. An MRI of the brain is not so invasive, but it's not an easy scan to undergo. And there you can see, this is a brain MRI, you can see these white things here. That's abnormal. It's not typical for Bing-Neel syndrome, but this is abnormal, so it's a sign that something is wrong in your brain. And if there's something wrong, you can do an operation for brain biopsy. That's of course has some risks, and also risk of dying of this procedure. So sometimes we try to avoid this procedure. And what you should always have is a lumbar puncture, dus een ruggenmerg of een ruggenprik. And a lumbar puncture, it's when a needle is, so when you have a bone marrow puncture, we do it right here. And when you have a lumbar puncture, it's in the middle, and we go through the spine, and we go to this area where's the spinal fluid. And then normally a neurologist is doing this procedure. And when you take some spinal fluid from patients with Bing-Neel syndrome, you can see these cells in their spinal fluid, and these are abnormal cells, and they are Waldenström cells. So you can have way too many of them. That's abnormal. They can look different. They don't look like normal lymphocytes anymore. They look like Waldenström lymphocytes. But what's really important for us as doctors, and you heard Dr. Garcia talking about it, is are these cells clonal? So also on the spinal fluid we can do flow cytometry, look at the proteins on the cell surface and see if they are all the same, therefore are derived from cancer. And we can also do the MYD88 testing on these cells and look if they have the same mutation as, for example, you have in the bone marrow. So this is the examination you have to do. And what's the good news is, if somebody thinks about it and you have the procedure, Bing-Neel syndrome can be treated. And when it's treated, there's also reversal of your symptoms. So it's very important diagnosis to make, because there are several lines of treatment possible with IV drugs or with oral drugs, and your symptoms can be much better after that. So it's an important diagnosis to make. So what are the milestones that we reached during this workshop, the IWMF? Well, 2 years ago we started a task force for Bing-Neel syndrome, and this has resulted, it was an international task force with hematologists, pathologists, neurologists in there, and we published a guideline. It will be online in 2 weeks, and so it will help other doctors for the diagnosis of this disease. And what we did is, so we did that to improve the recognition of this syndrome, but we also use it to help doctors what tests to do and which treatments to give. And we also defined some response criteria, so that is always the basis before you can start a clinical study. So all the foundation has been made to start a clinical study for treatment of this disease, but there's no study at the moment. Moving to another neurological disease, complaint of comorbidity, I should say, in Waldenström's disease, it's polyneuropathy. And of course that's much more frequent in this disease than Bing-Neel is. Bing-Neel only 1%, this is much more frequent. So what do we mean with polyneuropathy? We mean different things. You can have sensory neuropathy, and that means you can have tingling, change in temperature, pain, lack of coordination, or feeling of a tight sock or glove around your feet or hand. But you can also have motorial neuropathy, and then you have weak muscles, paralysis and painful cramps. And what's very typical about neuropathy, it's always on two sides of your body. So it's not left or right, it's always left and right. It's caused, the complaints are caused because there's nerve damage. And it always manifests at the longest nerves you have. So they are on your toes and in your hands, because that's the longest distance they have to go from your back to below or to your hands. And so it can be sensory, motorial, but also autonomous, and it can also induce pain. So always on two sides of your body. It's quite frequent in Waldenström's disease. Only 25 to 30% of patients have neuropathy already at diagnosis. And we think it's caused because the IgM protein or paraprotein that you all have reacts with a part of the nerve cell. So it damages the nerve cell, such as the myelin, and then there's inflammation of that nerve. And when when your IgM paraprotein targets your myelin, we can measure that in your blood as an anti-MAG antibody. But there are also other causes of polyneuropathy in patients with Waldenström's disease, so we have to look for that too. And one of them is amyloidosis, and I will discuss that at the end. There's cryoglobulinemia and POM syndrome, all very rare diseases, but please understand if a doctor is saying, I have to do some more tests because your picture is atypical, or if I want to exclude other diagnoses, it's an important differential diagnosis to make. So this is a picture of a nerve, so it's just cut and put on an electron microscope, so it's enlarged very tight. So this is the nerve, and this is the myelin that's around your nerves, and it's for the conduction of the electric signal through your nerves. And you see those black dots in there, so that's the anti-MAC antibody, the IgM that reacts with your myelin and forms a complex in the nerves, and that causes the neuropathy. So it's a distal neuropathy, always symmetric. And sometimes patients have an anti-MAC antibody, but there are some other antibodies too, some other types of, not only the myelin, but some other parts of your nerves that can be targeted. So the story is a bit bigger than anti-MAC, and sometimes no antibody can be found, but this is the most frequent one. There's another cause of neuropathy in Waldenström patients, and that's the neuropathy induced by the chemotherapy that is given to you. Here you see the typical places where patients feel their neuropathy for the first time. It's the same when it's induced by your IgM or it's induced by via the chemotherapy. And these are two drugs known for their neuropathy. So it's bortezomib and vincristine. They can both induce neuropathy, not only in Waldenström patients, but in every patient that receives this drug. And also sometimes anti-CD20 antibodies like Rituxan, rituximab, or ofatumumab can have some kind of a flare and increase your complaint. So we should be careful with that too. And what we notice, because these drugs can also be given to patients with other types of cancers, that Waldenström patients are extremely sensitive to this side effect. So Waldenström patients have more chemotherapy-induced neuropathy than, for example, myeloma patients have. So what should we do about the neuropathy induced through your M protein, so because of your disease? Normally we try to treat the disease itself, because then your M protein, your IgM will go down, and that can have a positive result only in half of the patients. So it's a very difficult comorbidity to treat, and that's because your nerve is composed of cells, but they don't divide very quickly. So when you don't divide, when there's damage in your cell and you stay there for like 2 years, the damage will be there for 2 years, because you can only restore when you divide your cells. So it's they divide very slowly, and so the chance of a positive result that your neuropathy gets better when the disease is treated is half, 50%. And what's of course important, if you have neuropathy, try to avoid the drugs that induce chemotherapy-induced neuropathy. So no vincristine and bortezomib, with very careful use, dosed once weekly, because they can increase the complaints you have. Pain medication is of course important, and we have special painkillers for this type of comorbidity. Some patients already have neuropathy, but don't have Waldenström's diagnosis. They have an IgM-MGUS diagnosis, so less than 10% of cancer cells in their bone marrow. But they do have a complaint, and it's very difficult for us to start a treatment, for example, chemotherapy treatment for MGUS that's normally a benign disease. And that's called an IgM-MGUS-related comorbidity. And when it's neuropathy, the consensus at the moment is that we should try only immune therapy, so with the anti-CD20 antibody Rituxan or rituximab for several administrations to try to improve this neuropathy. But also there, the chance of success is not that big for this complaint. For the neuropathy induced by chemotherapy, it's important that you stop the drug that causes this complaint. because there's no treatment besides that. Because if you stop in time, the complaints, the neuropathy can get better. They will resolve a little bit. So it's important to stop in time with your anti-Waldenström therapy, and sometimes it's difficult for patients because you want your disease to be treated and then your doctor is saying your side effect is so serious we have to stop or we have to lower the frequency or lower the dose. But in the end it's important because with these nerves you have to live the rest of your life, and there are other therapies you can try with less side effects. When we look at pain medication, these are the drugs normally used in the Netherlands. Paracetamol is normally not that effective, so we use special painkillers for these neuropathy complaints, and they take a while for their work, so don't stop too early, take them for several weeks. And I always advise my patients to be cautious with vitamin B6. It's not generally known, but B6 can induce neuropathy, and it's sometimes in those bottles with multivitamin pills in it, but your B6 should not be in there because a high B6 can induce neuropathy. And one of our most famous skaters we have, he won Olympic medals, had a bad season, no medal whatsoever, induced by high doses of vitamin B6. So stop that, please. So what did we learn in this workshop on this disease? On this comorbidity. Also here, there was a multidisciplinary guideline prepared. It's sometimes difficult to be interdisciplinary, so with neurologists, specialization doctors for pain and hematologists to come to a consensus. That takes time. But it was done by Dr. Shirley Dessau from England, and this guideline will be published within, I think, 4 weeks in the British Journal of Hematology. And what's important, that at the moment we have new medication, like BTK inhibitors, ibrutinib, Imbruvica, but also new oral proteasome inhibitors. So bortezomib is a proteasome inhibitor, but we have new variants. They are orally, and they don't have this side effect of polyneuropathy. So there are other options for the patients. That's important to know, but also we don't know what the effect is when you have polyneuropathy to be, that the complaint will be better after therapy. So this also has to be investigated. But there are drugs that do not induce chemotherapy in polyneuropathy anymore. So that's also important that most doctors will realize that there are other options for patients. So this guideline is also being published soon. Well, then to my last subject. I'm sorry, there were 3 subjects in a short time. And that's for amyloidosis. Amyloidosis is a very difficult disease to grasp. It's a disease not caused by the cells, like Bing-Neel, but it's also caused by the M protein itself. So like the neuropathy is caused by your M protein, also amyloidosis can be caused by your M protein. When some patients, we don't know why exactly, but some patients make a very abnormal M protein. It reacts with other proteins inside your body. We don't know why, but it's something that happens infrequently in IgM, but it does. And when it reacts with the other proteins, it forms insoluble fibers. And they are in your organs, and the organs will deteriorate, and then it will go slowly, 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 and at one point you will notice because you have some complaints. We call this disease AL amyloidosis when it's caused by an M protein. Of all the patients with AL amyloidosis, only 6% have an IgM M protein. All the 94% other people will have IgG or IgA M protein, and that's the M protein that's linked with multiple myeloma. So for IgM, Waldenström's disease, only 6% of the AL patients is caused by an M protein, so it's also quite rare. These are the symptoms that can be caused by amyloidosis, and because there is some the insoluble fibers will be in your organs, they will enlarge for the biggest part, but they can also be on your nerves, again polyneuropathy, fatigue, your kidney can become worse, you will lose protein in your urine, thickening of your cardiac wall, so your heart can't pump that effectively anymore, enlarged lymph nodes, bleeding, enlarged liver, but also diarrhea. And what's typical of patients with AL amyloidosis, several organs are being involved. So it's systemic, it's not one, systemic, so more organs are involved. And so this is something we can see in lots of diseases, so not typical, but this is something that we almost only see in AL amyloidosis, a thickening of your tongue, so it won't fit in your mouth anymore. It's very a difficult complaint, and you can, people start for the first time, they have a different speech, and sometimes you can see indentations of your teeth on the side of the tongue. So a little bit basic, so the principle of amyloid fibers is that you have a bone marrow disease, and these are the cancer cells, and they make an M protein, so this is an M protein, but when this M protein is very strange, more strange than normally, then it reacts with other proteins in your blood, so you see the change in shape, and they will fire your bloodstream. These are the insoluble fibers, fire your bloodstream. They can be in your whole system, so in your liver, in your bowels, in your heart, so they can involve many organs. What's typical what's different in IgM, so the red bars are IgM patients with AL amyloidosis IgM type, and this is the blues are non-IgM, so the IgA, IgG types. And there is a different pattern of presentation with this disease. So there's less heart involvement in IgM. A kidney is almost the same, but what's striking that soft tissue and also non-heart, non-renal, but for example in your muscles, is more frequent in the IgM AL amyloidosis. So the presentation of the patients is different than in a more common type of amyloidosis. And the underlying disease in IgM is of course lymphoproliferative diseases, but in non-IgM it's always a plasma cell illness, so MGUS or multiple myeloma. But in IgM it's lymphoproliferative or plasma cell, but in 14% of the patients they can't find any cancer cells in the bone marrow, or it's unknown in 28. So it's those 6% of patients we do need some more research on that. And from those lymphoproliferative diseases, so that's non-Hodgkin's lymphomas in general, the majority is Waldenström's disease, but also other non-Hodgkin lymphomas and also follicular lymphoma and chronic lymphocytic leukemia can induce AL amyloidosis of the IgM type. So what's new is in this workshop was already published just recently, June 2016 in the Journal of Clinical Oncology, and that's a new staging system. We do have a staging system for AL amyloidosis patients, but it's mostly, we needed a new one because the authors noticed that for IgM, the old staging system was not good enough. And in this staging system, we use 2 cardiac markers. So your heart is of course very important because when it's involved in amyloidosis, that's the highest risk. But also liver involvement and neuropathy is in this new staging system, and there you can stage patients into their risk of dying, and so their chance of survival. This is for a individual patient, not always good to know, because these lines do have a wide range of differentiation. So per patient it's not that easy, it's not so helpful, but for doing research, for example, these staging systems are very important. So then the treatment goal with amyloidosis. In Waldenström's disease, sometimes we say if we can control the disease, it's good enough. If your complaints or you can live with this is good enough. With amyloidosis, it's important to go as low as you can. So your M protein, it's a toxic M protein, it should be as low as possible. And we call that complete remission or very good partial response. That's the terminology we use when there's no M protein anymore in your bloodstream. So as low as possible. But the problem is AL amyloidosis patients are really vulnerable because their liver is involved, their heart is involved, they have diarrhea, and they really feel awful. And then we have to go very intense with our treatment, bortezomib, fludarabine, autologous stem cell transplantation even. So that's always a very difficult thing to do with these patients, and sometimes these treatments can't be given because they are too weak for this. What's very new is the anti-amyloid antibodies. I won't go into detail for this, but for the first time there are several antibodies now in clinical trials, so not available, but only in clinical trials, and they bind to the amyloid that's in your organ. By binding at the amyloid places, your own immune system will attack and eat up the amyloid. So that's, you can see an example of this. This is a patient, this was published in the New England. It was a patient, the black is his liver, a very big liver. And he was treated with some of the new anti-amyloid antibodies. And you can see that this is all amyloid, and after, I think this was 12 weeks, the amyloid was cleared from his liver. So very promising new therapies, but only in clinical trials at the moment. I will stop. I would like to thank you for your attention. Sometimes people ask me, how is it possible that such a prestigious workshop like the Waldenström workshop can be in Amsterdam? I want to share some details with you. This is Steve Trion and this is Chris. We visited them, and 2 Ajax, that's the soccer team of Amsterdam, did the job. Thank you very much.